Would you like to get rid of anxiety, mood swings, night sweats, hot flashes, difficulty sleeping at night, perhaps maybe even skin conditions? Would you like to do that? Well, have you tried going to your doctor and your doctor says, it's all in your head, or maybe there's nothing you can do. This is your new normal. If this is what you've been dealing with, I've got great news for you because we have Dr. Mary Claire Haver, and she's a wife, a mom, a board certified obstetrician gynecologist, a culinary medicine expert or specialist, and also the creator of the Galveston Diet. I am so excited because she's going to give us a set of tools so that we can use them when we are either facing menopause so that you can prevent certain things, or you're in menopause or after menopause, and seeing how you can enter this and lean into it gracefully. Hi, my name is Lillian McDermott, and I am a certified life coach and the host of the Lillian McDermott radio show Classroom. If this is the first time that you've been here, please know I've been waiting for you. This is a safe place where you can go to when you need a friend. It is my commitment to provide natural ways to heal, and it is my mission to make awareness, responsibility, and truth a part of our everyday life. And I hope you, my listening and viewing friend, will feel empowered to embrace a new truth and live the life of your dreams. And so today, like I mentioned, we have a treat. For those of you, again, that are suffering in silence or been told that this is your new normal, no more. Today's class may change your life. I'm hoping that it will change your life because we do have Dr. Mary Claire Haver. And so since our sole purpose in life to give and receive love and knowledge, I am grateful that she is here to do just that. Welcome, Dr. Haver, to the classroom. I'm so glad you're here.
I'm so happy to be here.
Thank you. Thank you. Well, normally when I interview doctors, when I first started this journey 12 years ago and interviewing doctors, when I started diving into the natural or a little bit more holistic, integrative, functional, I noticed that doctors would reveal to me that the way they were trained is not the way that they have continued. And I believe that this has happened to you too. So share a little bit about your background and what led you to this journey to help women with menopause.
Sure. So I was classically trained. I went to have an MD. So I went to a traditional medical school, LSU. So go Tigers, for my medical school. And then I matched into my residency in obstetrics and gynecology at the University of Texas Medical Branch. And I am so proud of everything I did learn in my medical school and residency. But there were just really big gaps in, how to take care of someone for overall health. And I was, practicing delivering babies, doing pap smears, providing contraception, counseling, taking care of, screening for cancers. I was doing all the things. And when I first got out into practice, I was kind of at the same stage of life as my patients. I was getting pregnant. They were getting pregnant. They were having babies. I was having babies. We were all raising our kids together. And so I didn't see a lot of menopausal patients until I got older and my patients were starting to go through perimenopause at around the same time I was. And that's when I really started to realize, I don't know if I know everything I should here. And there are some significant gaps in my education. And I think there's a lot more out there that can be helpful for people of this age, going through these stages. And what's being put forth to me by my very traditional education and training is not really allowing me to be as helpful as I think I can be for patients. So the biggest pain point at the time, which was my personal pain point, and probably one of the biggest life lessons I've learned through all this, was I was having unexplained weight gain. or unexplained inability to lose the weight. I had gone through a pretty traumatic event in my life at the same time I was late perimenopausal. So my brother had entered end of life care for his HIV and hepatitis. And I went home to take care of him, and just, he went really, really quickly at the end. And I just went right back to work after the funeral and never really processed those emotions and walked myself through, all of, we were such good friends, but I just, all the stuff involved in that. At the same time, I'm not sleeping. I'm having hot flashes, night sweats, all these things. And I was gaslighting myself. Like, I didn't even know enough to recognize my own perimenopause symptoms, because I was still occasionally having a period. So I was just attributing it all to grief, which was understandable, right? I was going through a horrific time. But then when the fog of grief was lifting, that 6 months, and I was feeling better and coming to terms with what had happened, I was still suffering horribly. And at that point I was like, wait a minute, I'm having these horrific hot flashes, night sweats. I feel terrible. I'm having joint pain. What are these headaches? And what really was driving me crazy was the weight I had gained through my grieving process, which involved a tremendous amount of simple carbohydrates in the form of goldfish crackers, and probably way too much alcohol. I had put on about 15, 20 pounds. And so, okay, grief is gone. I'm going to get back in shape. And I went back to those same tools I had taught my patients all these years of work out more, eat less, this obsessive, like, get to the gym, restrict those calories, and this weight will come off. And it wasn't working anymore. And I realized I was going through the same thing that my patients were going through. And I was feeling the same frustrations of, why did this used to work so well? And I'd lose a pound or two and it would just bounce right back on. Plus some, like, I had lost my equilibrium. I'd lost my resilience.
Wow.
And so I started to realize, wait a minute, I don't know enough here to realize that there's a menopausal connection. So my husband was actually the one who was seeing me, developing some very bad habits, and watching my daughters, who were teenagers at the time, watch mama obsess about the scale, complain about food, completely restrict, not enjoy my dinner, and like obsessively working out. And he's like, honey, something's up here. Your body, something's changing. I don't care what you weigh. This is not important to me, but like, you're obsessed and you need to figure this out because you're a scientist and you're smart. So go figure this out. Mm-hmm. So that kind of led me on this journey of, do I know everything I need to know about nutrition? Because they didn't teach me in medical school and residency. What am I missing?
How much nutrition did you were given during your time as a
honestly, it was like the Supreme Court's definition of pornography. You know it when you see it. That was good nutrition. We learned about scurvy and like severe nutritional deficiencies, but not, things were in our textbooks like balanced diet. No one taught me what a balanced diet was or what that meant, or other micronutrients, or, and so I really got little to no training throughout that 8 years of medical education. And so I called up, had taken care of, we had a really robust nutrition department at the university I was employed at. Like, these are PhD nutrition scientists who were doing groundbreaking research on protein in the elderly and working with an astronaut. We were very close to NASA here. And so, doing like really high level stuff in nutrition. So I called them up because they were all my patients. And I'm like, what's going on in menopause? Like, why is this happening to me and my patients? And they're like, well, we think it's something to do with inflammation. There's definitely something hormonal going on. It's more about body composition changes, less about just weight gain. And so, they gave me a ton of articles. And then I said, you think I can get a master's in nutrition? Like, is there a way for me to like do something online? Wow. So I found the culinary medicine program at Tulane, which is basically for people like me who were advanced medical professionals who wanted to learn medical nutrition to be able to help their patients.
Good for you.
And for me. And so I was like, I went to my boss and I'm like, I'm enrolling in this course. It was, several $1,000s. and I'm going to have to fly out to go take these labs and, but I can do most of this online. He's like, I think it'll make you a better doctor. Fine. So that's kind of where that journey began. And I learned all the stuff about anti-inflammatory nutrition, the Mediterranean diet, and fasting, and different fads and protocols and allergies and all these things. It was so groundbreaking to me because I'd never heard it in my life. And I thought, I think I feel something here that I could be helpful, because so many patients are suffering from this and they don't understand what's happening. So that's how the Galveston Diet was born. I really was just making, and medicine, diet is a pattern of eating. It's not a fad, or, it's not a quick weight loss thing. So I was trying to help my patients develop new habits, and myself, and I was the ultimate laboratory, to develop these habits so that they could lose the weight. And in the beginning, yes, it was about weight loss, but it really became about learning about visceral fat and inflammation, and lowering that, not worrying so much about the curves that you have, and really trying to hang on to your muscles. So it's just been this journey since about 2015 of
Wow.
me, this continuous improvement project. And that's how the Galveston Diet was born.
Why the name Galveston?
So I live here. It's where I've chosen to call it my home. It's where I've raised my children. It's where my community is. And I just didn't, it was for my patients who all live here or live around here. So I was never expecting to write a book or make this a worldwide program or anything. And it just sounded cute. And so I chose it after the place I call home.
That's wonderful. That's wonderful. Well, what excites me is when I interview naturopathic doctors or doctors that have chosen to go the naturopathic, it's one thing. But when I interview an MD who has furthered their education and has come to the conclusion, like Dr. Joel Furman, I don't know if you know who he is, but he is focuses on being a nutritarian, so focusing on nutrients. And basically with you and what you were doing, you're looking at foods that cause inflammation, foods that may cause this. So as you are going through all these and taking care of women and taking care of yourself that are going through childbearing years, all of a sudden you find yourself surrounded by women that are going through the same thing you are. So when you are, yes, you went through, and I'm so sorry about your brother, and loss is really difficult, especially if we internalize it, those traumas that hold on. But as you were going through this process and this journey, were you being told, this is in your head, there's nothing you can do, this is your new normal, like a lot of women do? Did you hear that from your doctors?
I was gaslighting myself.
You were gaslighting yourself. That's how good it is.
I was like, is this my new normal? Do I have to be like this? My mother had, she's 35 years older than me. So she had been on hormone replacement therapy. So but I just remember like her menopause, of being her in a dark room with the door shut, and this very dramatic time. Like, I had such a negative connotation of what a menopausal woman would be and what that looked like for me moving forward. I was like terrified. I didn't want to admit it. And I mean, I knew I was the right age. I knew that this was happening, but I was really, really reluctant. Like, I didn't understand about nutrition and what I call now the Menopause Toolkit. And I was really terrified of hormone therapy because of all the bad press from the Women's Health Initiative, which was announced the year I finished my training. Like I'm the last generation of healthcare providers who were trained in hormone therapy at all. And then it was taken away in 2002, right when I finished. And then, the American Board of OB-GYN has not been putting the latest in menopause research in front of us as our required continuing medical education. I mean, there's lots of great stuff there, everything in the world, except for menopause. Menopause just gets almost no training, maybe 6 hours of lecture in my entire residency, no menopause clinics. I just realized there's a huge gap here, and a gap that I'm just one little voice, but I'm going to do my best to shine the light on it.
And you're doing a great job at doing that. That is so wonderful that you are, because I have, me too. I usually the youngest person in the room as a Bible study fellowship, a Bible study leader, or whatever was going on. I was usually watching women soaked, drenched, fanning themselves. And I'm thinking, wow, what's going to happen to me? But most of them were overweight. And I thought, well, maybe it will be different for me. Well, in my 40s, when I turned 40, I had a partial hysterectomy. I had tumors in my uterus. And so they removed my uterus now that I know what I know now, would I do it again? Possibly not. But that's what I did. That's what I knew at the time. But that put me in a place that I wasn't expecting at the age of 40. 20 years later, I've tried a lot of different things that have helped. But hormone replacement therapy, which you mentioned a little while ago, not all hormone replacement therapy is created equal.
No, not at
So
all.
let's talk about that.
Sure. Sure. Okay. So, when we go into the world of naturopathic and holistic and again, like hormone therapy, it's not all the same. And so what I'm trying to do so much with my new book and in my clinical practice, for sure, I just have a menopause clinic now. It's the best thing I've ever done. It's like, I'm trying to marry the best of nutrition, exercise, possible supplementation, pharmacology, so that I can give a patient, sleep optimization, stress reduction, so that the goal is, not to just get rid of hot flashes. It's for you to thrive in your menopause, for you to not be plagued with chronic disease. Because what we're realizing now that menopause research is actually happening in a more meaningful way is that there are estrogen and testosterone receptors and some progesterone receptors in every organ system of our body. And when we go through the process of menopause, we are now having sex hormone deprivation, where we are expected to live without the benefit of those hormones for 30 to 40 years, depending on how long we get to live. Menopause is not optional if you live long enough. Okay. We haven't figured that out yet. And the best thing I could do is keep your 25-year-old ovaries humming till you died, but that's not happening. And so hormone replacement therapy can go a long way, this replacement concept or menopause hormone therapy.
Yeah.
But it's not perfect. And you must check all the boxes in order to live your healthiest life and suffer the least. And so, it's less about, sure, everybody would love to rock a bikini. I could care less. I just want to play with a grandbaby and climb a mountain and not burden my children with my illness and chronic disease and have them worried all the time and just have this really healthy, fulfilled life. I don't expect not to age, but suffering from menopause doesn't have to happen.
Correct. Yes. Well,
so my hormone therapy 101.
Okay.
So let's talk about, there's 3 classes of hormones when we talk about, there's hundreds of hormones in our body. So when you see some of these catchy, like internet things like hormone balance and all these magical products coming out, I'm like, what hormones? What are you talking about? Insulin's a hormone, leptin's a hormone, ghrelin's a hormone, estrogen, testosterone, DHEA, estradiol, vitamin D is a hormone. And so when I'm talking about in our menopausal world, I'm talking about the hormones made by the ovaries. Okay. So we are born, most people don't realize this, with all of our eggs at birth. They start forming when we're still in our mothers. Okay. And at 5 months in utero, we're 5 months, 4 months to go, we're cooking, is when we have our maximum amount of egg cells, and they start deteriorating in the womb. And by the time we're born, you have a certain percent that are gone. By the time we're 30, we're down to 10% of our egg supply. And by the time we're 40, on average, we're down to 3%. And when you use up those eggs through this process of attrition and a process of ovulation, they're gone forever. And you no longer have estradiol or progesterone production from the ovary. And you may have just a little bit of testosterone going kind of in the background. Our peripheral cells will make some estrone, but it's usually not clinically significant unless you have a lot of fat cells creating that. So when we talk about menopause hormone therapy, we have to look at estrogens separately, progestogens separately, and then your androgens separately. So estrogen is the one that's the best studied, and we know probably the deprivation of estrogen is doing the most amount of damage to us, okay? And so replacement, you have options. Everything's made in a lab. So I don't want to make you seem like you could just take yam and rub it on your body and it would magically create estradiol. That's not how it works. It has to go to a lab to be chemically processed. So, but they are plant-based. So at most estradiol, so if you look at just plain beta estradiol, that is usually coming from yams, from plant-based, and that is most chemically identical to what your ovaries used to make. So that is what I typically prescribe. there's also ethinyl estradiol, which is synthetic. And there's a couple of other estrogens that are available. Premarin, which has been around forever, is conjugated equine estradiol estrogens. So there's about 10 different estrogens in there. It comes from the pregnant horse's mare's urine. It's not ethically, I really have an issue with it, how it's made. I never prescribe it. It's not my favorite, but it's been used for a very, very, very long time. There's also no generic for it. So when I'm prescribing estrogen to my patients, I'm sticking with estradiol. Okay. So now I'm like, okay, patients, we're going to give you back some estradiol. Now, how am I going to put it in your body? There's different risks depending on how we put it in. So we have systemic options, which is we're treating your brains, your bones, your heart, your lung, your kidneys. We're getting in your bloodstream. We're going everywhere with it. And we have topical options. So topical means we're just trying to treat what we're putting it on or in. So there's vaginal options, and there's also some skin options. So the topical options are very, very, very safe, and typically there's a pill for the vagina, there's a pill, there's a cream, there's a ring, and there is, I think, a suppository available. For skin, which is newer, there's some creams that you can use for cosmetic reasons, and we can talk about that later. But let's talk systemic. There's also oral. So systemic oral therapy, everything we ingest orally has to go to the liver for processing. We swallow it, it goes through the gut, gets picked up by the portal vein into the to the liver circulation. When that bump of estrogen, because we take it once a day, it's like a dose once a day, you see a couple of things happen. We see a slight uptick in inflammation, leading to possibly an increase in triglycerides. And we see a slight increase in blood pressure sometimes. And then we can also see an upregulation of our clotting factors. So I have a lot of patients or followers who say, hey, I've been told I can't take estrogen because I've had a blood clot or have a family history of blood clots or have MTHFR or whatever clotting disorder. And I'm like, just do non-oral. When we skip the pill and we use it transdermally or transmucosally or inject it, we can bypass that increased risk. And now you're at your baseline. So I just like to reassure patients, you still have an increased clotting risk because of your genetics, but I'm not going to make it worse by giving you a non-oral form of estrogen.
Yeah.
So we move on to progestogens.
Well, before we go there, if you don't mind me asking, for women who have had breast cancer, and I've done lots of shows on this, and the fact that the doctors are starving them from estrogen, what do you tell somebody who's been told, oh, you can't have a topical cream or estradiol? What would you tell them?
Vaginal estradiol has never been shown to have any increase of reoccurrence of cancer or nothing. It's so minimal. It's such a tiny dose. And, so topical estrogen therapy, even with active breast cancer, is considered to be safe. Great. And so there's no reason to suffer with genital urinary syndrome of menopause, even with breast cancer. Now, depending on your stage, how far out you are from your breast cancer, what your genetics said, if you've had your ovaries removed, there are patients who are very safely on systemic hormone replacement therapy, very low dose, very highly monitored by their physicians. Because if a woman is diagnosed with breast cancer, she still has a 90%, the chance that she dies of breast cancer is still minimal. Okay. The number one thing she's going to die of is heart disease. And the number one preventative therapy for heart disease is estrogen.
Amazing, right? Isn't it amazing how it comes full circle?
Like, you just have to take the drama out of it and all of the hoopla. And you know what? This is supposed to be shared decision-making, meaning let's talk about my risks. I'm your doctor. We're going to talk about your risks and benefits. And then we're going to make a decision together as to what you want and what risk you're willing to tolerate. I can't think of a medicine that the male gender would go to their doctor to discuss, where the doctor would be like, I'm not doing that. Nope. It's going to give you, no, that just doesn't happen. And that why we are gatekeeping this from women is outrageous to me.
Yeah, it is. Okay. So I just wanted to ask that because there's so many women that are suffering, that have had breast cancer or any cancer.
They've been told you have hypertension, you can't take it. Not true. You have diabetes. Actually, your chance of diabetes getting better is much higher on your estrogen therapy than it is off. Your cholesterol will get better more than likely with a transdermal estrogen. It's craziness to me.
Very good. Okay.
So,
So let's continue the progesterone.
okay.
I think
So
we're going to
then
go there.
if you have a uterus and you're taking estrogen and you don't have progesterone in your uterus in the form of an IUD, it's not an option to have progesterone. Okay. You must have progesterone to protect the lining of that uterus. Okay. However, if you've had a hysterectomy, progesterone is optional. For some women, progesterone can be very helpful for insomnia and very helpful for erasing thoughts at night, and sometimes very helpful for mood disorders.
Yep.
And so I tell that to patients when we get started. Okay, you've had a hysterectomy. Let's start with the estradiol. Let's see how you do. If you continue to have X, Y, and Z, studies are showing that it might be reasonable to go ahead and add the progesterone. Now, how do we put it in your body? Progesterone is the natural form, the bioidentical form is progesterone. Okay. It's a huge molecule and it is not absorbed very well through the skin. So
I
if
don't
you
work
know
well
what
with
you're
it,
doing, you do not want a topical progesterone. It's not enough to protect the lining of your uterus. So for my patients, we do for most of them, oral micronized progesterone. Couple of caveats with that. It's in an oil base and the oil is peanut oil. So if you have a peanut allergy, we're going to have to do something compounded, a little bit different, or maybe the combi pack. I mean, we have other options, but also for some people, the oral progesterone can make you feel a little bit dizzy, lightheaded. It's very sedating, which is why we recommend taking it at night and why it helps with sleep. So, but if you're still feeling sedated in the morning, we may have to go down on the dose. Like everything is trial and error in hormone therapy. You're different. Your body is different. Your needs are different. We do not have a cookie cutter, one size fits all. And we just have to kind of, know that might take a little bit of finesse to get to the right formulation for you.
Interesting. Interesting, because I was given progesterone cream, and many doctors said I could not take progesterone because I didn't have a uterus. And so when I finally went to the right place, when I started looking in the right direction, that was the first one. They said, "Are you having problems sleeping?" Yes, you need progesterone. But many doctors don't know that. So now that we know, you need to research it. For those of you who are listening, you research it as well, so that you can go to your doctor, empower yourself to go to your doctor and be able to get the dose. Now, you mentioned there were a couple of types of progesterone, not just the cream. I'm talking about the
Right.
oral
So,
one.
so
You said it
the,
has to be
the,
made with peanut oil. What was that?
well, the one on the market that's FDA approved, that is covered by insurance and very, very, very cheap is called Prometrium. And
Oh,
it's oral micronized progesterone and it is in peanut oil. So if you have a peanut allergy, that's not for you. We may have to compound a different type of pill, might
yeah,
be a
I
little more
use
expensive,
compounded. Yeah.
or do a combi patch or whatever. I'm always trying to find the most economical option for my patient, knowing that we can try these other things later if the kind of standard thing I usually start with doesn't work, but I want them to not have to choose between their hormone therapy and a car payment or a vacation or a dinner out. They don't have to. I can find them usually for most really, really economical ways to get this hormone therapy.
Good.
And so that usually insurance will cover. So testosterone, your androgens, that's another tough one. Thank you, FDA. No approved option for women. We're going to fight for it. So insurance will cover it. But for now, there's the T-stem gel, which is made for men, and it's 10 times the dose of what we need. So your healthcare provider has the option of trying that. But I've really, at least in Texas, had a difficult time getting the pharmacist to fill it because he or she has to break open a box that's set with a 30-day supply for men and only give you 3 of the 30 packets. And they're left with 27 packets they can't sell. And so it's really just not economically feasible for them to do that unless they give you the whole box and then you have like a year and something's worth and you have to pay out of pocket for it. And so to get around all of that, my workaround is I usually have a testosterone cream that will be compounded. It's absorbed well. Most patients tolerate it great. And there's another thing to kind of watch out for with testosterone. There's some really popular options out there in the form of pellets. I don't have anything against the pellet themselves. It's just another method of delivery. You're kind of stuck with it for 3 months. If you don't like it, they can't take it out. You have to deal with it.
Yep.
But they are routinely overdosing patients.
Yes.
So therapeutic with, a therapeutic woman with a normal testosterone level at 25, when you're your highest libido and you're knocking the world out, right? 45 is your average level, nanomoles per liter or whatever, the standard measurement. And so 70 is kind of high normal. So that's kind of where I try to keep my patients, 45 to 70 in there somewhere, 90, above 90. So if a woman came to me and was like, I'm having all this hair growth, I'm losing hair, and I check a testosterone level and it's over 90, it's my job to look for a tumor. The BioT company is in their paperwork is telling the clinicians to run a woman between 150 and 250 for therapy. 236 is where a man starts. And so so they're super therapeutically dosing. I've seen women come to me after having pellets months out, still 3, 4, and 500. And I'm not exaggerating.
It happened to me.
It's very frightening
Yes.
for me to realize, and they're having so many symptoms and side effects. Sure, their libido's better, but like, my God, the acne, the hair, they're growing hair in places they never wanted it. They're losing where they wanted their eyebrows. And so I'm like, listen, I'm just trying to get you back to a 25-year-old, not a 13-year-old boy, so, or a 19-year-old young man. So
yeah.
I really have a problem with that, to routinely recommend supraphysiologic dosing without a single study to support that. Its safety, its efficacy. There's no placebo-controlled trials. These people are making billions of dollars off of these women. But for some women, it's the only time they've ever been offered hormone therapy. So I can't blame her for just, and your healthcare provider's job is to do exactly the speech I'm giving you. All of the options, all of them.
Informed choice is so
That
wonderful. Yeah.
personally profit them. You are not a profit center for your doctor. You should never be.
Yeah.
So your hormone therapy options should be a magnitude of things that you can choose from, and that you and she together decide what you want to start with and what's going to work best for you and what's in your budget. And to like railroad you into, we just do pellets, or we just do this compounding thing, or we just do whatever, I think is doing a disservice to our patients.
Absolutely. I had a situation that the doctor had tried to duplicate what somebody else had done. And I was feeling horrible. I was feeling really, really bad. And I had gone to my doctor and she said, I could tell that you have a lot of testosterone. There were some signs in my body that she could tell. And so she had it checked and it was 435. It was 400. My skin is usually smooth. It completely changed. I had acne. I was irritable. It was not good. And I joked with my doctor and I said, were you trying to make me grow a penis? What was it? What was your goal? Because this was not good. This was not good. And so I never went back to it. I never went back to pellets because of that experience. Now I had experienced wonderful, I had wonderful experience, but that ended it right there.
Yeah.
So I do the creams. I do the, I tried the progesterone cream, but that doesn't work for me. I went back to oral. I love doing things as naturally as possible to avoid going through my GI. So if I can do it as a cream, I'm glad to hear from you that the testosterone and the estradiol is great to do the
transdermal. Yeah, they're great. There's a really great testosterone gel. There's just no generic for it. And patients love it, but it's really tough to get it covered.
Yeah. I have I can only use the cream once a week or so. It's just too much. But it's all compounded. I have a compounding pharmacy that's a sponsor in my show. That he's always been very, very wonderful to kind of like work with me and change things and tweak them. But that is the thing that most of us don't understand, that this is a partnership with your doctor and how you're feeling because there's no one size fits all. Like if you're 5'6" and weigh 120 pounds, do you get the same hormonal as a person who's 250 pounds, 5'6"?
Or well, also if your level's 50 and my level's 50, you could feel amazing and I'm still suffering. I'm still having classical symptoms, yes. So it is a lot of trial and error, back and forth, see how you're doing. I do not run routine lab levels unless I think they're toxic or they're not absorbing. And I'm tweaking based on her symptoms more than arbitrary blood work.
Yes. And that's wonderful. I love, from the moment I saw what you were doing, I loved everything that you talk about. And I'm grateful that you're in the classroom. And for those of you who want to learn more about Dr. Mary Claire Haver, I want you to go to her YouTube channel. That's how I stumbled upon her. As a matter of fact, my friend Karen was the one that told me about her. And we started doing some research and we loved, just because you're an MD doesn't mean that you're going to do everything that the allopathic community tells you to do. When you find an MD that is willing to listen and be curious about something different for you, maybe you're not a cookie cutter. So whatever is cookie cutter doesn't work for you. And that's why we empower you to make these decisions. It's called informed choice. Ask as many questions as you can. Don't go into the white coat trance. I hear and obey. Make your own trail, make your own path. And so what I am here to ask is that you go to whenyounneedafriend.com. Please subscribe to the website. We're trying to build our list because we never know how long this information can stay on. I've had 30 videos removed on in the last year. And in the last year, it's been 20. In the last, since 2022, I've had 30 videos removed. So I want to encourage you to continue seeking these new truths that work for you, not necessarily the budget of your doctor or the pharmaceutical company or whatever company is trying to give you this pill. Always choose a natural first, and then and go with whatever needs to happen. And so when you go to whenyounneedafriend.com, like I said, please subscribe. Then once you subscribe, you need to opt in. Go to your email and opt in. That means say that you did subscribe. Then while you're there, just like and follow me on all social media. Check out my sponsors, support them the way that they're supporting the classroom. Check out my Shop Now bag. These are all Lilly approved products, Lilly approved products, from makeup that's synthetic free, chemical free, organic, all the way to pain management without any drugs. And so go check it out. Some of those products are affiliate products. Some of them are not. They're just products that I absolutely love, and I want you to know about them. Then last, you can, as you know, we just finished the emotion code body code with Dr. Bradley Nelson. It was a wonderful success. But we now are focusing for 2024, and we have the I Am the Solution Natural Health Summit, which is February 3rd, 2024. If you register right away, you'll get $24 off until December 31st. That's your last day to get that discount. So life is urgent. Choose wisely. Last but not least, you can become an enrolled student in the classroom, and whether it's $1 or $1,000 a month, a one-time donation, whatever the case might be, of your time, your talent, your treasure, everything is very much appreciated. Just by sharing this video, you are helping the algorithms, because if we get enough people liking this video, the algorithms cannot touch us. They can even take our video off. So I want to encourage you to do everything you can to help grow the classroom. I also want to encourage you to go to galvestondiet.com. This is where you'll find all the information, and it'll lead you to her YouTube as well, and how you can reduce belly fat and learn what the foods that are inflammatory in your body. So I want to thank you, Dr. Haver, for doing this, because someone's got to step up and say, you know what? It may not be good for you. It might be good for somebody else, but not for you. And then that's the person that needs to really reach out and do something else. So when you're with your website, they go to your website. What are some of the things that they can find that are self-help, that they can do, self-help courses or whatever, any speaking engagements that you might have?
So we have our website at galvestondiet.com, but we do a tremendous amount of education around menopause, your options, how to talk to your doctor, articles you can hand to your physician, in support of hormone therapy, questions to ask, blood work to ask for, how to find a menopause informed physician, because they're kind of hard to find. These things are prescriptive. And so you're going to need a certified healthcare provider that can write prescriptions in order to get hormone therapy. But just to realize that there's much more to menopause care than just hormone therapy. Nutrition, exercise, sleep, stress reduction, community is all so very important. To always tell your menopause story to everyone who will listen, so that we normalize this and we, make this a normal part of getting older, that doesn't scare anyone, that, at 35, you're not even thinking about menopause. It's not going to be a big deal. You're going to handle it when you get there. It's going to be so easy. You're going to know what your options are, and that we can all just age as healthy as we can.
I love it. I love it. And so are these courses, can you start learning in your website
we have
at
blogs,
any time?
and you can sign up for different courses for, we have podcasts, we have links to our YouTube channel, to Instagram, to TikTok. So we have so many wonderful resources on our website.
That's wonderful. And for people that are wanting to maybe talk to you, do you also have,
I have
you
a
said you have
clinic.
your clinic,
Yeah.
but can you do it
Yeah.
online as well?
So I don't. I
You
have
don't have,
about 400 people on a waiting list to come and see me.
I can imagine. I
In
can
Texas.
imagine.
So I practice outside of Houston, Texas, in a town called Friendswood, but I am beginning to train providers.
That was going to be my next question.
Yeah.
And as you
So
train them, will you be able
I'll be
to?
able to, they'll be on my website. Like, go
Right.
see Dr. Smith in Arkansas, go see, nurse practitioners, whoever in Alaska, just so that they're not working for me. They're just going to come and learn with me and then go off and like be the best menopause providers that they can.
Wonderful, wonderful. So let's go on with, some of the things that we hear from our doctors are, this is the new normal. We talked about that earlier.
Mhm.
But what are some of the things that we as women and our husbands too, because our husbands pay dearly for our malfunctioning hormones. When we say, a doctor says, no, this is not something you can do, or this is what I offer, because I've had doctors that I've tried to get off some medications and use natural means. Like I got off all the asthma medication I've been taking since birth. And I use vitamin C and Lobelia once in a while if I need to. And that's what I use, hydrogen, hydrogen peroxide nebulization. So other things that I use when I need that. But when I went to my doctor to get off this drug that I was on for 9 years compared to chemotherapy, he basically said that if I changed whatever he was offering, that I could never come back. He kicked me. He basically made me sign a document saying that he's not responsible for me getting off my asthma medication. And I'm not telling anybody that they need to do the same, but this is my story. And kind of bullied me into not doing what I felt was right. What are some of the things that we as women should accept and not accept from our doctors? And we just say, sorry, this relationship is not working.
Any conversation around menopause where they will not even have a conversation about hormone replacement therapy. No, I won't give it. No, I don't do it. No, I don't believe in it. That's unacceptable. And you should be able to call ahead and make sure that is even, see if that's off the table or not. Number two, this is a part of aging, tapping you on the knee. This is your new normal. Look, menopause is inevitable. Suffering is not. I think it's unreasonable to expect them to know anything about nutrition, much about exercise, really anything about lifestyle. They're just not trained that way. What I did was very, very special. And, because I just had a passion for it, so much so, I was in a financial position that I could take time off and go learn these things. And, not every physician is in that position, and they're under tremendous pressure.
Sure.
They're overworked. They're having to see patients in 15 minutes. So I try to give you tips to like get your story down really quickly to, checklist and things you could just hand to the doctor so that, you can make the most out of that appointment. But I mean, do as much research. That this term is just getting overblown, but, call ahead, ask to speak to the nurse in the office and say, do they, like how many menopausal women does this actually see? Because everyone's website will say they do menopause care.
Yeah. That
is more than just a hysterectomy. So, and so many of us just weren't trained in how to be proficient. So the Menopause Society, which used to be called the North American Menopause Society, I am a certified practitioner through them, has a list of certified practitioners. So they're not perfect, but they've it's a really hard test to take. And it does require a lot of outside reading and knowledge to be able to pass it. So that's a great place to start, to find someone who's at least menopause informed.
Very good. Very good. So I just got your book yesterday, the PDF. I don't have a copy. I like to always show it. So can you show it? There you go. That's the book that you need to get. If you click onto the blog, you will have all this information where you can get the book and everything. So with that in mind, in your book, when I was looking at it, I was shocked how much fiber is in avocados. So let's talk about how avocado fiber and how fiber helps with menopausal women.
Yeah. So fiber is probably one of the least utilized nutrients that we have out there. And most women are only getting 10 to 12 grams of fiber per day, and we need a minimum of 25. I personally push for 35 grams per day in my diet. And you really should search for foods that are rich in fiber, like avocado. And when we eat fiber rich foods, we also get all these other nutrients, that are in the foods rather than going straight to a supplement. Really nutrition through food first, and then we supplement any gaps that are there. And our gut microbiome changes in menopause. We see when they've done stool studies through the menopause transition into postmenopause, a woman's gut microbiome will approach that of a man's. We lose a lot of biodiversity in the gut, and all of this is so important for brain health, for gut health, for inflammation markers, for everything. And so what feeds our gut microbiome is soluble fiber. And so if we're not getting enough fiber, they don't have enough food to stay healthy. We're starving our gut microbiome. So, that's one thing. It slows down the absorption of sugars into our bloodstream. Fiber slows that process down. And so we don't get the insulin spikes. And one of the, hallmarks of menopause is insulin resistance increases independently of age. And so we are, making our body more resilient to the natural insulin resistance that and diabetes that menopause brings. And so it keeps us full longer. We don't eat as much, and it's just the foods rich in fiber are so freaking healthy.
Yeah.
Otherwise, and thank God I love avocado because it just makes my life so easy.
Yes.
I used to avoid avocado. It's so high in fat. Oh my God. It's full, delicious, rich, healthy fat that keeps you full forever. I love it. I use it in everything. I top it with everything. I'll eat it plain with salt and a spoon right out of the shell. And so I know I'm getting 10, 12 grams of fiber, half my fiber a day just by that avocado.
It was amazing because, there's a lot. As a matter of fact, I make a quinoa bowl because we just did, I don't know if you know who Dr. William Davis is, but we just did a course called Super Gut, and it talks about eating fat and eating all these, fibrous foods, and how the low fat, high carb diets are just really killing us. And so tell a woman that it's okay to eat all this fat, and it's just like they don't believe
Really
you.
hard.
And
Yeah.
then you'll talk to these women that are overweight, that are starving themselves, and then they look at my plate and they go, why do you eat so much? Well, because I need this much food. I love to eat. I'm a foodie, but I choose to eat the foods that are going to be as healthy as can be. But tell a woman that's overweight that they can eat all this fat and all this protein and all this whatever, they're like in shock. So I was making a quinoa bowl with avocados and walnuts and strawberries and coconut cream and all this because I make my own yogurt, and I ferment it for 48 hours. And so I make that, and it's just so delicious. It is so good. But tell a woman that is overweight. So talk to that woman who has let's talk about the different kind of fat, the curves kind of fat and the visceral fat.
Right. So, one of the biggest lessons I learned through all of this, my menopausal education was body composition and what, these two different areas of fat storage in the body. So we have subcutaneous fat, which is the fat we've known our whole lives. It gives us curves. It might give us cellulite. If we have a lot, it can put wear and tear on our joints, but so much of it is genetic. And it just defines kind of our culture and who we are as a person. And we've demonized it because thin was healthy and thin was the way to be. But really, subcutaneous fat is in modest amounts is not unhealthy at all. It's just kind of how we're built. Intra-abdominal fat, what we call visceral fat or belly fat, is the fat that's deposited in our intra-abdominal cavity, wrapping around our organs, also contributes to fatty liver disease. And so it's the intra-abdominal fat that skyrockets in perimenopause and menopause. All of a sudden, a woman is having an expanding waist, waist size where she never had it before. And it's directly linked to increasing risk for chronic diseases. And so, sure, it responds to starvation, but that's not our goal here. It also, though, women who consistently have 25 grams or more of fiber in their diet per day have less visceral fat. Women who watch the added sugars in their foods, not fruits and vegetables, things added in cooking and processing and alcohol, Less than 25 grams a day seems to be the magic for most people.
Mhm.
Probiotics, eating foods rich in probiotics, like you're fermenting those fermented foods, the the miso and the
Kombucha,
kimchi,
yeah,
and
yeah,
kombucha and all that. That's not my jam. I like yogurt. And so I do supplement with a probiotic on the days I don't have yogurt. And so, and then turmeric, it's a really powerful antioxidant, has been shown to be helpful. Zone 2 training, I love resistance training, but when you're doing cardio, I try to stay in zone 2, like for longevity. It seems to be kind of the sweet spot. And that's where your heart rate is just below breathless. Like you can talk, but it's kind of struggle. And so I do a lot of my Zoom calls, and I've turned my treadmill into a walking desk at home. Not podcast, because I try to look nice and not be huffing, but
We always
I've
do.
really, by focusing on like movement and modest levels and staying strong, I've really been able to like completely change my life and my health.
So you did talk about turmeric, but there's also supplements. I read in your book magnesium and the importance of magnesium. So would you like to talk about what are bare minimum supplements if you're menopausal?
Right. So I think 80% of my patients are deficient in vitamin D. So the vast majority of them, I think everyone should be taking a vitamin D supplement. You can go up to about 4,000 to 5,000 a day without worries of toxicity.
Mhm.
But if you're on more than that, you should be monitored by a physician to make sure you're not getting too high. And I have patients on a lot higher than that just have absorption issues, or we don't go in the sun as much. Our gut's not as healthy. There's a lot of reasons why our vitamin D's are low, and it's such an important hormone in our body. And so most of my patients are on that. Most of my patients do take fiber supplementation every day. There's a couple of types of collagen out there. One has Verisol, which I did it for vanity, for wrinkles and cellulite. And, but there's also one called Fortibone, Fortibone, which has been studied in postmenopausal osteoporotic patients. And after 4 years, it takes a long time to change a DEXA scan. 4 years on Fortibone without like bisphosphonates or any of the traditional medications, they showed improvement in their bone
Wow,
density.
I'd like to look into that. Yeah. Does
Yeah.
that have
So
calcium in it? Because I've heard that calcium
oral
causes
calcium
heart disease.
supplementation is not the way to
I
go.
know,
You want to get it from
exactly.
your food. That is
Yeah.
one. Kidney stone. So oral calcium supplementation is not the same as
Yeah.
getting calcium from your food, and
Yeah.
actually can be harmful, both
Yes.
cardiovascular and
Yes.
in kidney stone formation. So I do not have a single patient on calcium supplementation
Good.
unless she's
Good.
got parathyroidism and just pees it out all day long. So, it's very, very rare. It's not routine. I do not recommend routine calcium. I mean, like, you must get your calcium from food.
Yeah.
And
We
so,
we had Dr. William Davis said, if you and Dr. Thomas Levy as well, both cardiologists that have stepped over to this other side, and they said, if you look at your supplements and it has calcium, throw it away, because that is the risk factor of calcification in your arteries. And I thought, oh my gosh, we have been told so much that we need to
I said it a million times
relearn.
to my patients, take your times. So the other, I quite often, when a patient is struggling with sleep, and we've maximized her pharmacology, and I'm not a fan of Zofran, of any of the sleeping aids that are, if it's a temporary thing, or you're traveling to a different time zone, sure. Magnesium L-threonate is great for that. It crosses the blood-brain barrier. It's been studied in ADHD. It's been studied in SSRI-resistant depression. So it's been shown to be really helpful. I'm taking creatine. So I don't have a lot of natural muscle mass. I've been really working on that. And there's some great studies for women in menopause and creatine supplementation, but you have to eat the protein and do the lifting. But it's just another tool in that
I
tool.
got a little tool. I'll talk to you about it later, but I was able to build muscle later on in life because of a quick little hack that I have that I'll share with you off the air. But for those of you who watch the classroom, we're talking about the B3 bands. You can find it in my Shop Now bag, but that is something that you guys can research as well. So we have about 2 minutes left in class today. For us women that we're just beginning to dip our toe in being assertive and loving ourselves, giving ourselves what we need, what would you say are some of the key quick bullet items that we need to really start looking into?
So if you know something's wrong, nothing's changed. You know, you don't have new stress in your life. You're eating basically the same. You're still doing the same workouts. And you can't put your finger on it. It's your hair, it's your skin, it's your nails, it's your gut. It's something, it's likely perimenopause. And so start educating yourself as soon as possible. You know, even if your periods are still regular, you know, that's the last thing to go typically are the cycles. And so listen to your body, realize, start educating yourself, start getting ready, start lining up a provider well before you need one, you know, and open your mind, get your family history, make sure you know what your risks are, you know, so that you can have an informed conversation with a healthcare provider about what your options are.
You know, I really love what you're doing. You are doing so much to empower women. And one of the reasons I'm so grateful that you were in the classroom today, I want to encourage all of you to tune into galvestondiet.com, get your book. You can go to the blog and just click on the book. It's the Galveston Diet. And so it's time for us to do whatever it takes to not buy into the lie and recreate your story, recreate your life. And that's what I love about what you're doing, Dr. Haver, that you are helping women rewrite the story for menopause. So thank you so much for that.
You're so welcome.
And so all of you, please remember, and I hope that this will not be our last conversation. I hope you'll be able to come back in the classroom. And please remember, we'll be right here waiting for you worldwide at whenyouneedafriend.com. This is Lillian McDermott and Dr. Mary Claire Haver, wishing you love, peace, joy, and unexpected abundance. Make it the best day ever. Good job. Good job.
The opinions and advice expressed on the Lillian McDermott radio show are intended for the individual callers and guests on the program and are presented to our wider audience solely for general educational purposes. Please act responsibly and consult personally with your own medical, psychological, or nutritional expert before taking any steps